Welcome to the other side of Lucy Letby. In episode 94, we're going to have a look at an article on Substack that was flagged up to me on Twitter by someone I can't recall, but thanks for doing that. And this is, I think, a pretty lightweight article, but seeing as it's out there, we may as well have a look at it. And on its face, and certainly in the mind of the writer, this is a very clear-cut and straightforward issue. And when you're biased, in other words, when I don't mean intentionally biased, I just mean when your thinking is biased, everything looks clear-cut. But the reality is that medicine is not clear-cut. In fact, very often it's the opposite of clear-cut. So we look at this, it's called Letby, the Insulin Deep Dive by someone called Ben Cole. And Ben tells us in his bio that he studied, at some stage he studied criminology. And the problem I have with Ben's deep dive is that it's not deep enough. So I'll leave you a link to the article, but here we go through it, maybe not all of it, but some of it anyway. The insulin cases involving babies F and L led to 2 of the 3 unanimous guilty verdicts against Letby, and are widely regarded by those who believe in her guilt as the smoking gun. During the original trial, expert witnesses in clinical chemistry and pediatric endocrinology testified with certainty that the babies had been administered insulin. Notably, Letby's defence at the time did not present any expert witnesses to dispute these conclusions, nor was the insulin evidence challenged in subsequent appeals. Now, Letby's new defence lawyer, Mark MacDonald, has opted to submit separate challenges to the insulin-related convictions to the Criminal Cases Review Commission, an international expert panel whose views are informed by Professor Jeff Chase, a mechanical engineer, and Helen Shannon, a chemical engineer. A joint expert witness report with 6 experts from various backgrounds. While I'm not medically trained, this is what the article says, in insulin-related matters, I've drawn from transcripts, medical and legal sources to support the claims I'm presenting. If I've made any errors, feel free to point them out in the comments. Carries on. So, do the claims made by Letby's new defence hold up under scrutiny when it comes to the insulin evidence? This article critiques the insulin-related evidence presented by new defence experts in the Lucy Letby case, focusing on biochemical findings, expert testimony, and alternative explanations. It argues that the insulin-to-C-peptide ratio observed in babies F and L are consistent with exogenous insulin administration, not natural causes or assay interference. This piece examines the defence's alternative theories, showing they are scientifically implausible or unsupported by clinical data. It also highlights inconsistencies and questionable reasoning in the experts' conclusions, including flawed interpretations of glucose readings and reliance on individuals outside their area of expertise. Drawing on legal precedent, particularly the Windsor case, WINZAR, the article concludes that the immunoassay results are both reliable and admissible, and that the defence's challenge are unlikely to succeed in any future appeal. So, very confident, very sweeping. The accuracy, reliability of the tests. Both summaries challenge the accuracy and reliability of the immunoassay tests. One of the frequently cited experts in Letby's new defence team is Dr. Abdel Ismail, a retired professor and consultant in clinical biochemistry and chemical endocrinology, and former director of pathology services. That would be NHS pathology services, I assume. His credentials are well established. In the recent BBC Panorama documentary, he described the immunoassay results in the Letby case as completely worthless due to the lack of verification. Let's now examine the specific claims made by Letby's new defence regarding the testing process, particularly where they assert that the jury was misled in the following areas: testing, So this is the expert panel testing that the results of the immunoassay test can be relied upon, that the Roche immunoassay test method used in the Royal Liverpool University Hospital was specific for identification of insulin alone, endogenous or exogenous, neither of which are correct. So it's the expert opinion that you can't rely on these tests, and that the specific Roche immunoassay test used in the cases of BBF and BBL can distinguish between endogenous and exogenous insulin. And then the second expert evidence is that the background error rate, so ERR, the error rate, this is at least 0.5 to 2%, despite excellent quality control for the type of insulin immunoassay test used, which the jury were not made aware of. So we have the experts, Lucy Letby's experts, saying that the immunoassay tests in general are not reliable enough. I agree with that, and I think most doctors would agree with that. That the Roche immunoassay specifically is not good enough, it's not specific enough, and I would agree with that. And that all of these tests have error rates, and that's just a matter of fact. A jury should be told what the error rate is. Now, they may not take any heed of the error rate, but they should be told about it. In the Lucy Letby case, they were told there was no possibility of error, or no one entertained the possibility that there could be an error. And our writer here, Mr. Cole, is going to use Anna Milan in her evidence in court to underpin why she thinks the tests are reliable. And does that enable you to express any view as to the confidence you have in the results you've just explained to us? So that was Nick Johnson, the prosecutor, to Anna Milan. Very confident in the result. I mean, the pattern is very clear-cut. So that's the pattern, the insulin high, C-peptide low. It's not numbers that, obviously, the C-peptide is below the limit of quantification. Question, yes, but the insulin is very much in the measuring range. So I have no doubt about the numbers that were produced. Every procedure was followed that we could follow for any sample. There was nothing different about this sample. And that's a very interesting start to the whole question of what did they measure, what was used, what was the techniques, everything that to do with these blood tests that were carried out on these babies, preterm babies. Now, you have to remember that the prosecution theory is that in human beings, in preterm babies, adults, all that stuff, there's always more C-peptide in the blood than there is insulin. And the reason for that is that the insulin and the C-peptide are both made at exactly the same time from exactly the same components, but one of them decays faster than the other one. And when insulin decays faster, it's going to leave behind more of the C-peptide. And it's just as simple as that. Except, of course, it isn't. And the problem is that for BVF, for example, the insulin was measured at 4,600 something, massively high. Enough insulin to kill an elephant, never mind a preterm baby. But the C-peptide that was reported as less than 169. Oh, he carries on with Anna Milan during her testimony in the trial. Sorry, pausing there comes a point where there is such a small amount that even your computer your testing equipment can't detect its presence. That's Nick Johnson to Anna Milan, and she says, correct. And the threshold for that, presumably, is 169. And Anna Milan answers, yes, it is. Question, so when it says less than 169, that could be 0. That could be 168 or anywhere in between. Answer, basically it means that we cannot accurately give it a number because it could be anything below that or it could be completely 0. But the assay itself can't distinguish anything below that number. So how true is that? Well, it's not true at all. The Roche ELISA immunoassay test for C-peptide will read down to 3 picomoles per litre, depending on how you set the machine up. So for some unknown reason in the dim and distant past, the Liverpool Women's Hospital seemed to decide, for no apparent reason, that they were going to pick 169 picomoles as their cutoff. They weren't going to test any lower than that. Not that the machine can't test lower than that, or the immunoassay can't measure lower than that. It can measure lower than that. It can measure down to 3. And why is that important? Well, it's important because, generally speaking, when you're looking at exogenous insulin as a cause of death, either by accident or through a criminal act, you don't usually see any C-peptide at all. You see 0, or the lowest readings you can get. And the reason for that is very straightforward, because you're putting external insulin into the system. The pancreas, your pancreas, or the victim's pancreas, is reading the level of insulin in the blood and turning off its own capability to make insulin, because it doesn't need to. It's coming from outside. So you're going to have all insulin and no C-peptide. And given that the half-life of C-peptide in adults is anything between 20 and 30 minutes, any C-peptide that's already in the body when the insulin infusion, poisonous infusion starts, it's going to be gone pretty quickly, and you're not going to see any C-peptide at all. But if you take a sample from someone and you send it to a laboratory for insulin C-peptide, and they're 12 hours or more into a hypoglycemic episode that was caused allegedly by insulin going into the body, then you're not going to see 169 picomoles per litre of C-peptide. So it seems to be very important for the prosecution to make it out as if 169 equals 0, when that's not the case. 169 measured in a Roche immunoassay test means 169. Because if you set your machine to stop measuring below that number, you have to reach that number first before the machine knows to stop measuring. But many people, even amateur doctors like me, would question the validity of a test that didn't give you 0 when you were looking at insulin poisoning. This test was taken at 6 p.m. on the day after the insulin infusion was supposed to have started. You have reached, apparently, over 4,000 picomoles per litre in the blood. So what is C-peptide doing there at all? Why is there 169 picomoles per litre of C-peptide there at all? It shouldn't be there. The C-peptide should be reading 0 or 5 or 6, something like that, at the most. And this is a big problem. With BBL, the reading was 234. And what that means is, if you take the C-peptide separately, if you only measured the baby's blood for C-peptide, and you took random babies, preterm babies, and you measured them for C-peptide, those readings of 169 and 234 would be found in about 40% of the babies in that cohort. So we have a kind of 4 out of 10 babies are going to be in that range when you measure C-peptide. And remember, even though these tests are often done together, insulin, C-peptide are often done together, they are 2 separate tests, 2 separate immunoassays with different chemical structure, so they're not related to one another in that respect. So having a relatively normal C-peptide in a baby is not very convincing that there is insulin poisoning. And if I was the Court of Appeal judges, or if I was explaining that to a High Court judge, that's basically what I would say. You would expect this to be 0, not 169 or to 34. That is very concerning, and it would make me in clinical practice question what I was looking at. Do we question these things all the time in clinical practice? Yes, we do. And what do? We ring the lab and we ask them to check again. And that's what Professor Adele Ishmael meant when he said that they were completely worthless due to the lack of verification. In the real world, if you threw up a test like this, a massively discordant relationship in a biochemistry test, you've got massive amounts of insulin present and normal amounts of C-peptide in the same blood sample. So 2 tests taken from the same sample. You're going to question the validity of that, either on the side of the insulin or the side of the C-peptide. And you're going to check that again, and that's called verification. And in every article you will read in a medical book about the use of immunoassay tests, they are used, but in general, or certainly in my experience, if they throw up an abnormality, they are rechecked, they're verified. Don't forget, most of these tests that are going to be done in a laboratory in a hospital, the vast majority of them are going to be normal. They're going to be within the range you would expect the blood sample to be. And even when a blood test is abnormal, no matter what the blood test is, it usually isn't so bizarrely abnormal. And then the next thing is the clinical scenario for BBF and BBL. They weren't sick enough to have that amount of insulin in their bodies. Clinically, they should have been having seizures, respiratory failure, cardiac arrest, all kinds of very serious life-threatening problems with that amount of insulin in your blood. But they weren't. And they have simple clinical explanations to explain the very limited accurate blood tests that were taken at the time they were sick. They had roadblocks to their treatment, so the babies weren't treated aggressively enough to get the blood sugars up. And when they were finally treated aggressively enough, the blood sugars came up to normal. And we have done different podcasts on this. But the clinical picture of the preterm babies was that they had largely uneventful, pretty normal hypoglycemia, which you see in preterm babies. And about 30 or 40% of the babies will get episodes of hypoglycemia. It's such a common problem. And we understand that it went spectacularly wrong several weeks after the test for BBL, when the laboratory underwent a voluntary quality assurance program. And this article says it's worth noting that David Rose, an investigative journalist whose reporting had previously led to 3 defamation rulings against the publication he was writing for, authored an article for Unheard in which he stated, blah, blah, when the Liverpool lab analysed the sample using the Roche immunoassay, it claimed its insulin level was 962 units, a wildly inaccurate reading that was 788% too high. However, its C-peptide finding was much too low at 130 units. Hold on, I thought that it couldn't measure 130. I thought it cut off at 169. Oh, apparently not. Just 14.7% of the true level of 873. And again, we've talked about this before, but this is catastrophic for the prosecution. This tells you that a random blood test of the type that the Letby babies had, when it was run through Liverpool Women's Hospital, gave back exactly the results that we're seeing here. Wrongly. So we have the potential for having very high insulin levels, very low C-peptide levels due to laboratory error. Exactly as Professor Ishmael said. That's why you can't rely on these things on their own. You have to do multiple tests so that they're concordant, or you have to use a different type of testing to measure the same thing if you get a very abnormal result. And to give you an idea of just how crazy I think that people who think Letby is guilty are. This article goes on to say, Mr. Rose's investigative skills, that's the journalist who wrote this story, appear to have shown little improvement since the defamation cases, so an ad hominem attack, as the reported C-peptide level of 130 picomoles per litre is simply not feasible. Why is it not feasible? The machine, that's what the machine measured, 130, and that's within the range of the test. Why is that not feasible? It was wrong, but why is it not feasible? Quoting again from the article, at the time the samples were analysed, the laboratory equipment at Royal Liverpool University Hospital was incapable of detecting levels below 169 picomoles per litre, a fact confirmed by Dr. Milan during her testimony at the trial. No, it's not that the equipment was not capable of detecting below 130, below 10. It's that the 169 was an arbitrary number chosen by Liverpool Women's Hospital to cut off, below which they wouldn't test. Such a fundamental lapse in reasoning should be deeply embarrassing for Mr. Rose. And if this information was disclosed to him by Letby's defence, well, I know that it wasn't, and relates to the materials withheld from the court, as suggested in their summary, then it represents a serious blunder on their part. Rather than it being a wildly inaccurate reading, which it is, which it was, that would cast doubt on the reliability of the results, which it does, it can only be a reporting error. Oh, so according to this guy, this cold guy, it can only be a reporting error. Well, surely that means that the really bizarre results in the cases of BBF, BBL, were also reporting errors. Then we get a really classic piece of Lucy Letby is guilty in this writing here. When the figures on the report that are attributed to the Royal Liverpool University Hospital are reversed, then you have insulin levels of 130 compared to 108 and C-peptide level of 962 compared to 873. A typing error in the report doesn't do anything for Letby's appeal. It would also mean that Dr. Wark was justified in saying our lab was performing well when giving evidence. So there you have it. There is a magic solution to every problem in the Lucy Letby case. Well, let's just reverse the numbers here. It was a typing error. This is a laboratory computer, a machine that types out. Somebody doesn't sit down and type by hand. The machine spits out the numbers that are put into it by its software. And it's got nothing to do with whether the laboratory is performing well or not. I just told you that 90% or whatever of the tests that are going to go through that are going to be normal tests. No one's even going to look at them a second time. But when you get abnormal tests, and when you particularly get them bizarrely abnormal, you have to check your machine, because that might be an error, which nobody wants, except, it seems, people who think Lucy Letby's guilty. And then he gives a rather bizarre link to a YouTube channel with someone who has a PhD in something or other, and they make some of the most outlandish comments that I couldn't be bothered watching it or listening to it too much. I mean, the most outlandish comment they made when they were trying to undermine Professor Xu Li, when he said that in the case of BBF, the line going into the baby was tissued and therefore no glucose was getting to the baby. That's the reason that the blood was low, part of the reason that the blood was low. This nutcase in the YouTube channel that this guy quotes pulls out a paper from the European Journal of Endocrinology or something that's talking about using a subcutaneous probe to measure insulin in diabetics. So the subcutaneous probe is going to tell what the blood glucose level is. And this probe is so good that they have reduced the lag time between the blood glucose measurement and the reaction of the device under the skin. And from this, according to PhD woman, Big Tam, we can infer then that if you dump a load of dextrose into the tissues, the extracellular fluid, the interstitial space or the third space, it's going to find its way into the bloodstream. And therefore, Dr. Shuli's explanation that when you see a massive amount of extracellular fluid damaging the baby's leg, that fluid isn't going to put glucose into the blood. But of course it's not going to put glucose into the blood. What do you actually think we're looking at when we see it? We're looking at a big bubble, a big swollen bubble of dextrose. And that dextrose is actually destroying the tissues that it's coming into contact with. And that tissue damage and the pain and distress of all of that is going to drive the blood glucose lower. I mean, it begs the question, why do we bother going to the trouble of putting central lines in or peripheral lines in? Why do we bother doing that when we can just shove it all in under the skin? Anyway, I said last week, the world's a crazy place and it's getting crazier. And this is just another example. I think if Mr. Cole is going to quote people, he should quote people that have a bit of credibility. And then he moves on to forensic quality and gold standards. So according to the expert panel, the testing did not meet acceptable forensic standards at the Liverpool laboratory in terms of analytical specificity. Now, some people are going to argue with that, and that's fine, because Act Rapid, which was the insulin that was supposedly used by Letby, and human insulin are identical. Chemically, they are identical. So therefore, these tests cannot tell them apart. In fact, gold standard mass spectrometry can't tell them apart. But it means if you can't tell them apart, then it's feasible also that these extraordinary high levels of insulin were actual human insulin. There is no reason why they would not be. Because we go on in the rest of the statement from the expert witnesses and they say, analytical specificity, chain of custody, control testing for interfering substances, which Liverpool Women's Hospital didn't do. That's not a forensic standard, that's a clinical standard. If you get a very high reading like this, the laboratory technician would generally do the test again to control for interfering substances, other substances that can give you that false high reading, and obtaining confirmatory results using alternative available methods or another laboratory. That's what you would do in the real world. That's all that the clinical experts or the expert panel is saying. This is not the way we usually do things. And then this writer goes back to Big Tam on Facebook again to get a reason why this isn't relevant in this case. Starting at 9:30 mark on the link video, Dr. Oliver, Big Tam, references data from Roche, the manufacturer of the immunoassay test, to explain how potential sources of interference have been largely mitigated by the test design. She also notes that many interfering substances would produce insulin readings far lower than those observed in the two babies. Letby's case isn't the first where insulin immunoassay has been used to secure a conviction, and it's not the first time their reliability has been called into question. Well, Letby's is the first case where an immunoassay test was used to infer guilt from insulin poisoning in a preterm neonate, not in an adult, in spite of the fact that, as I've said many times before, it also says on the Roche immunoassay packaging that the accuracy of these tests was validated in Germany using the pooled plasma or pooled blood, pooled serum of 57 healthy adults. Nowhere on the Roche site does it say what the accuracy of the test was in pooled blood for preterm babies. Now, I would have thought a scientist like Big Tam would have wanted to make sure that when they were looking at data sources, they would always be comparing apples with apples and not apples with pears. But no, Such is the I know best attitude, and Lucy Letby must be guilty attitude, that normal scientific standards go out the window, and any old serum will do, any old plasma will do, any old reverse number typing error of a reverse number will do, which is just so sickening. So let's look at this Deborah Windsor case and the reliability of immunoassays. Well, of course, Deborah Windsor, I don't know much about the case, but she was convicted in July 2000 of murder and received a sentence of life imprisonment. Ms. McCarthy has been convicted of the murder of her husband, who had been found unconscious and hypoglycemic. He was taken to the hospital but did not regain consciousness. Hospital laboratory tests revealed that Mr. McCarthy had a very high insulin level and, wait for it, an unmeasurable level of C-peptide. So straight away, I don't know anything about the Windsor case, but it isn't comparable to this. It's not comparable to this for two reasons. We're talking about a preterm baby here who has completely different physiology, completely different biochemistry to an adult. And in this case, no C-peptide was found at all. Whereas in the cases of BBL, BBF, the C-peptide readings were in the normal range. So apples and pears. And if we look at the Court of Appeal judgment, the Court of Appeal found that if the insulin was endogenous, then apart from insulin antibody syndrome, it could not have been caused by any of the other conditions canvassed by Professor Bagshaw, namely the possibility of small insulinoma in the pancreas or other cancers, hyperplasia, that's cell overgrowth, of the beta cells in the islet of the pancreas, and fatty changes in the liver, indicating the possibility of failure to degrade insulin, who had himself conceded that the evidence was consistent with exogenous insulin, and neither Dr. Ishmael nor Dr. Wood had ruled out this possibility. Well, again, that's not equivalent to the Lucy Letby case, where you have the experts who are ruling out this as a certainty. Because we're talking about preterm babies here, we're not talking about adults. And you will note that Dr. Ishmael, the person criticizing the use of the test in the Lucy Letby case, appears to be one of the doctors who agreed that the same test was sufficient in this adult scenario to determine exogenous insulin. So he's hardly a biased witness then, is he? He's not a Letbyist, as they call him. And then in this article, it goes on to give more of this Court of Appeal judgment about this Windsor case. And it says, Professor Gamma's cautious approach, this is the judges, to the immunoassay test is not unwarranted in general terms and is acknowledged by all the experts who gave evidence before us. So to me, that's an acceptance by the court that we have to approach these immunoassay tests with caution. His evidence that the tests were performed by Guildford and the FSS, whatever that is, would be incapable of conclusively excluding the possibility of interference in an uncertain clinical picture mirrors that of Professor Marks at trial. However, in accordance with his evidence before us, once we are satisfied that the immunoassay tests are entirely congruent with the clinical picture of exogenous insulin, and there is no alternative natural cause that has been identified, this is capable of verifying the results obtained by Guildford Laboratories. And as far as I'm concerned, and as far as others are concerned, we are not satisfied that the immunoassay tests are entirely congruent with the clinical picture of exogenous insulin and that there are no alternative natural causes that have been identified. And the main reason that we say this is the case of Baby Y. Baby Y was supposed to be the third insulin case in the Letby trial, but Baby Y never went to trial. So Baby Y had exactly the same blood picture as Baby F and Baby L. Very high insulin, normal. C-peptide and mild hypoglycemia. But this baby was signed off as being poisoned by Lucy Letby, by the experts that give evidence against Lucy Letby. That's Professor Hindmarsh, Bowen, and Evans. But when they looked at this case again, they realised, oh, there is something wrong here. This baby had that blood picture because of medical reasons, for purely normal reasons. And we'll just have a look here at a paper called Neonatal Hyperinsulinism, a retrospective study of presentation and management in a tertiary neonatal intensive care unit in the UK. So the object of this, the abstract, reports of hyperinsulinism typically focus on infants managed by highly specialised centres. However, neonates with hyperinsulinism are initially managed by neonatologists and often not referred to specialists. This study aimed to characterise the diversity in presentation and management of these infants. So the design was a 7-year retrospective study from January 2015 to December 2021. It's very recent. And they studied 99 cases were identified. They were severe, treated with a drug called diazoxide, that was about 20%. Moderate, clinically concerning hyperinsulinism, not treated with diazoxide, 30%. Mild, biochemical hyperinsulinism, for which neither gestation or birth weight correlate with clinical severity. And the severe group received a higher concentration of intravenous glucose compared with the moderate group, and lower still for the mild group. At diagnosis, the intravenous glucose intake was similar to the severe and moderate, but higher compared to the mild group. In the severe group, term infants started diazoxide, so it can even happen in term babies. And the National Congenital Hyperinsulinism Service was consulted for 23 infants, and 3% were transferred. So the conclusion was that the study highlights the diversity of clinical presentation, severity and prognosis of neonatal hyperinsulinism, irrespective of birth weight and gestational age. Most infants were small rather than large for gestational age, and the majority had transient hyperinsulinism and were not referred to the National Centre or treated with diazoxide. And further research is required to understand the breadth of neonatal hyperinsulinism and optimal care. So there you have a disease state that occurs in newborn babies, most of them preterm, where for whatever reason these babies produce a lot more insulin than they normally would. They have hyperinsulinism. They're very variable in how they present, from severe hypoglycemia to non-severe hypoglycemia. And they would have, therefore, elevated insulin levels, perhaps normal, variable, very variable, normal C-peptide levels, but not no C-peptide levels. So they would perfectly fit what you would expect to find in a blood test for these types of babies. If you read this article, they make an argument that because the baby was non-ketotic, so they weren't making ketone bodies, that is a characteristic of hyperinsulinism. But that's a characteristic of hyperinsulinism in adults, not in preterm babies, because preterm babies can't make ketones anyway, or the extent to which they can make them is very much compromised. So they're going to be low, very low ketone bodies or ketosis in these babies anyway. So again, you can't compare a preterm baby with an adult, which is what they did in this trial. The article has more blathering on from Professor Hindmarsh saying that you would have 5-to-1 ratios and 10-to-1 ratios of C-peptide to insulin. That does not apply to preterm babies. It does not apply to preterm babies. That is adult medicine or older child medicine, but it's not neonatal medicine. And Professor Hindmarsh is a pediatrician, not a neonatologist. So the judges shouldn't have any problem with this at all. So you get an idea of what this article is saying, what people in general say about Lucy Letby, most of which they say is complete rubbish. And then he gives a whole section to what are the alternatives, and he narrows them down to the alternatives, which again don't make any sense. But for argument's sake, the alternatives are BBY. BBY had a natural picture in the blood, or a disease picture in the blood, but natural causes of exactly the same hyperinsulinism that these people say that BBF and BBL had. And we've just heard in the last article that we need more research in 2021. We need more research to understand the breadth and scale of this problem. So we can't say with any certainty that a single immunoassay test can provide enough information to draw the conclusion of exogenous insulin poisoning in these babies. They are not Windsor cases. They are not adults. Then this guy tries to get into a whole load of technicalities which don't make any sense about different classes of antibodies, IgG and all that kind of stuff. And as usual, they just limit everything down to their understanding of things. Autoimmune diseases, as if a baby can have an autoimmune disease. And they say silly things like it's only prolonged insulin exposure that will cause a baby or a person to make antibodies to insulin, and that this scenario clearly doesn't apply to baby F and L, and nobody says it does. And then he has a go at Helen Shannon, the chemical engineer who gave help to do the very complicated mathematics that's required to calculate the possible dosages of insulin needed in a modelled system for a preterm baby, not an adult, in a preterm baby. So it's a skill, this mathematical skill is not a skill that doctors would generally have or need. So you require engineers who are using mathematics in their work all the time to do this mathematical modelling for you. And this modelling is used in medicine and for various things, but it's not generally the doctors who write the models, it's the engineers or mathematicians. But the unconvincing author of this piece criticizes Helen for something that she said in an ITV documentary. Helen said, something that is unique to neonates is that they have quite a high level of antibodies in the blood. It comes from their mothers. So because the antibodies bind to the insulin doesn't remove from the body. And the levels of insulin bound to the antibody goes up and up and up in the bloodstream. It doesn't have any effect on the child at all. It just floats around. Now, remember, this is a mathematician giving a description of a well-known phenomena in children. He says, the author says, it bears repeating, Helen Shannon states that these antibodies have no effect on the infant. Yet, babies F and L were undeniably hypoglycemic. So again, so what? The bound insulin, that's what it's referred to when it's picked up by these antibodies in the blood. The bound insulin is inactive because it's bound. So it doesn't have any effect in the baby, but it would have the effect of showing up on immunoassay tests, depending on the antibody, depending on the test, because again, these are preterm babies and they're not adults. Let's have a look at another article, last article we look at. And this is an article entitled Insulin Autoantibodies in Cord Blood from Neonates with and Without a Sibling with Type 1 Diabetes Prevalence and Characterization. So now we're looking at the unique circumstantial and biological nature of cord blood. The cord blood, which is also the blood circulating around the baby just after birth and for weeks afterwards, is not the same as adult blood because it contains a lot of maternal antibodies and other immune chemicals, some of which we don't yet know. But this says, results of this, you can read it, I'll leave a link. Results, specific insulin binding activity was noted at birth in 8 out of 12 neonates with diabetic siblings, and then 79 out of 112 babies with no diabetic siblings. None of the maternal samples from either group were insulin antibody positive. By age of 3 months, the insulin antibodies in the baby's blood had normalized in 90% of the neonates in both groups. So there you have it. Insulin binding autoantibodies, exactly of the type that Helen referred to in the ITV documentary, in 79% of newborn babies in varying degrees. And more importantly, it goes on to say that protein A, so protein A is a laboratory protein that's used to try and dislodge an antigen, in this case insulin, from the antibody in the laboratory. If you put protein A and it's from a staphylococcus, if you put it into solution with this insulin antibody complex, it might knock the insulin out of place. Well, it didn't do that. So these were very heavily bound and difficult to remove. So they were very stable anti-insulin antibody complexes. And they were coming from the baby. They were coming from the baby, something to do with the baby, because the mother's blood was clear. And as we've seen from that paper, it takes up to 3 months before these anti-insulin antibodies and this anti-insulin milieu that we don't really know about disappears in the baby. But most of them would normalize much quicker than that. But we're talking about, in the cases of baby F and baby L, we're talking about measuring insulin within days of the babies being born. So if we're going to use immunoassay tests that were developed for adults to be used in the treatment of diabetes and diagnosis of diseases like diabetes, then we have to control for the variation in the preterm baby. We have to find methods whereby we can account for all the anti-insulin antibody activity within the baby, whether it's directly related to antibodies or not related just to antibody-like structures in the baby, because we know from these studies that most cord blood anti-insulin activity is not from passively transferred maternal IgG, as this clown tried to claim, but likely reflects a transient unique phenomena to a neonate's blood at birth. Why it's there, what the purpose of it is, nobody knows, but we just know it's there. And when the expert panel stated that there should have been controls put in place to account for the presence of anti-insulin antibodies, which, as we know, are pretty sticky, these ones that are not displaced by protein A and they're not displaced by another protein called insulin-like growth factor. But in any event, controlling for this interference or cross-reactivity with this immunoassay test didn't happen in the cases of baby F and baby L, or indeed baby Y. But it should have happened. But as I said to you, the Lucy Letby medicine is just part of a story. So you just take a story, you just take a part of a story like insulin, high insulin, low C-peptide. You try to make the low C-peptide look like no C-peptide, even though you don't actually say that. You feel to tell the jury that these are really incongruous, these blood tests, because the C-peptide part of it are actually normal. So they don't make any sense at all. You try, in fact, you succeed in getting a jury to believe that a baby has exactly the same type of blood, immunologically and every other way, to an adult, which it doesn't. You don't tell the jury that the immunoassay tests were verified and validated by Roche for use in adults using pooled adult serum, but they are not validated nor licensed for use in preterm babies. So I've read through this article. It's a little rubbish. It's like everything else that's said medically about Lucy Letby. Just need to boil it all down to the simplicity of babies are very complex because they're not complete. And you can't compare babies to adults, which is what they did in that courtroom. And that type of expert evidence is a deceit. And it is precisely the sort of thing that a court of appeal, the CCRC, should be looking at, and I have no doubt will be looking at. So beware your experts on Substack. You need to think these things through, whether it's made up, non-documented, skin discolorations that should never have been allowed into court because they wouldn't have found their way into a civil court, or whether it's invented diseases like injecting babies with our intranasal tubes, delayed time bomb effect, or emboli, pages missing from the defence bundle as revealed by Phil Hammond on Twitter today in relation to baby O, where Dr. Breary had put the needle into the baby for whatever reason we don't know. But according to Michael Hall, the expert witness for the defence, who was never called, that sheet was missing from the records that he got. So all of this stuff is exactly the sort of stuff that an appeal court needs to look at. So we'll leave it there. I will leave all these links to you. You can read them if you want. I hope you learned something from that. I hope you got something from that. And we just have to carry on. And I'll see you in the next episode. Bye.